Thank you for providing the opportunity. So today I will present about a few interesting cases which I come across. So first of all, I will just like to highlight what are the common symptoms in the gastroenterology. So mainly sometimes the most common symptoms like heartburn, constipation, nausea, on and off loose stools. But in this sometimes patient can present with some of the red flag symptoms. Patients like can have difficulty in the swallowing, bleeding per rectum, weight loss, anorexia, jaundice. So we have to evaluate throughout in detail. So here is the case number one. She is a very young girl, 23-year lady, presented with complaint of occasional stucking of the food and heartburn for say about 3 to 4 months. She was taking on and off PPI and the antacids, but one day suddenly she has complaint of blood in the vomiting, which was a very small amount. No other complaint. Vitals and the other histories were not significant. On the blood routines, hemoglobin slightly on lower side, rest of examination was normal. So what it can be? So the young lady, reflux disease, first we should keep, let patient might have severe reflux disease, can have the Sats's ring. Other thing, in the young girl can have eosinophilic esophagitis, can present with the ring, furrows, and can have the blood in the vomiting. Sometimes reflux can present with the ulcers, mallory waste tear, or lastly, we can keep malignancy. It's a rare occasion. So what I found out on upper GI scopy, you can see there is a diffuse infiltrative friable lesion in the lower esophagus, just above G junction. The similar kind of friable patch was also present in the mid esophagus. On narrowband imaging, on endoscopy, which found to be a invasive lesion likely to be malignant. So I've taken the multiple biopsies, and the biopsies showing it is moderately differentiated squamous cell carcinoma. So it is very unlikely that young patients without any, you can say, risk factor present with malignancy. But sometimes we ignore the common symptoms like heartburn, where we consider it is a reflux disease, but suddenly one red flag symptom like blood in the vomiting, and we diagnose as a malignancy. Later on, the patient lost the follow-up. The second case, similar, but it is an elderly patient, 65-year male, chronic alcoholic, has a complaint of progressively difficulty in swallowing of the food and also the pain while swallowing. No other significant history, but yeah, patient had similar complaint 2 years back, and endoscopy was done showing a reflux disease. Other thing, that on examination when patient came has tachycardia, and he had both the lower limb poliomyelitis. So patient mobility was restricted, examination wise normal. On the day of examination, slightly higher counts, CRP was high, and SGOT was slightly higher side. This was on the day of discharge, which came to be normal. But on endoscopy, so what it can be? So patient has already GERD, now is complaining of progressively difficulty in swallowing. So maybe patient developed stricture. Other thing, the pain. Pain could not be explained with the stricture, so it might be some infections like Candida, CMV, HSV, or it can be the malignancy. But surprisingly, what I found, it was completely blackened mucosa. It's a necrosis. So the risk that whether to go ahead with the endoscopy or should I stop here? But this finding was not present in the proximal esophagus. It is seen in only mid and distal. I again asked, I stopped the endoscopy while doing because there is a risk of perforation. I asked the relative whether patient has consumed any caustic ingestion or patient has any poisoning, but he denied. So with the risk of small perforation, I went ahead, found out G junction below the cardia level was normal, stomach was normal. So the thing is, we have to diagnose that why so much necrosis has happened. I taken the multiple biopsies for fungus, CMV, and which all came negative. So it was just acute esophageal necrosis. So this entity is usually very rare, mostly occurring in chronic alcoholic patient, mostly who are like bedridden, immunocompromised state. So I given the treatment with broad spectrum antibiotic, IV PPI, sucralfate, antacids. Just after 2 weeks, when patient came on follow-up, the repeat endoscopy showing the pinkish mucosa, that all the necrosis has gone. But the thing is that patient may develop future in stricture, so we have to just keep the follow-up. The another interesting case, 33-year male patient came with diarrhea, say about 3 to 4 months, semi-solid, with nighttime frequency, occasional blood, with periumbilical pain, and weight loss, significant weight loss, about say 10 to 12 kg. No other significant past history, addiction history, vitals were stable. On the blood reports, even the hemoglobin was also surprisingly normal, except the CRP was high, rest of thing was okay. Stool showing plenty of pus cells with very high calprotectin, CT suggestive of terminal ileal, mild wall thickening. So I did the colonoscopy. So before that, on looking at this, most likely that patient might have some chronic small bowel or with large bowel inflammatory diarrhea, likely to be inflammatory bowel disease, or it can be the tuberculosis as patient has significant weight loss. On rare, it can be malignancy. So lower GI scopy on terminal ileum found out multiple aphthous ulcer even in the right-sided colon and the transverse and descending colon. So it looks like Crohn's related aphthous ulcers. So I did upper GI also to see whether the similar kind of ulcers were seen in the duodenum. So stomach and duodenum, the similar finding, and the biopsy find out to be Crohn's disease. So young patient nowadays, we are seeing rising trend with Crohn's disease. I have given the treatment with budesonide and the mesalamine, and patient has improved. Now the patient has normal frequency with regained the weight. Another interesting case, 64-year male, diabetic, alcoholic, recently detected cirrhosis of liver, came with black color stools, melena. Say about 1 or 2 days. When patient came, apart from the mild pedal edema, rest of examination was okay. On routine investigation, HB was fine, slightly lower platelet, SGOT is more, INR was borderline. So first, in the cirrhosis, everyone was thinking it may be varices. But sometimes varical bleed has very, you can say, very moderate or high amount of blood loss. So hemoglobin slightly to be lower side. Here the hemoglobin was not so much drop. So varices, yeah, we should always keep the first, but it can be less likely. Patient can have GAVE, ulcers, malignancy, or sometimes the colonic diverticuli or vascular ectasia or colopathy. So on an upper GI scopy, I found out only just reflux disease, no varices, fundus was normal, no GAVE. So I did the colonoscopy, and the colonoscopy they found out 2 large pedunculated polyp, out of which one was showing the recent sign of bleeding. So I cut it out both the polyp with and The polyp was showing tubulovillous adenoma with high-grade dysplasia and low-grade. So the thing is that nowadays, usually the polyps are asymptomatic. Polyps doesn't cause bleeding, but in very rare case, it can present with the bleeding. And all these polyps are the precursor of colonic cancers. So after the 50 years of age, the risk is high with colonic cancer. So this was the last case. 70-year male complained with progressively increasing painless jaundice with itching about 1 month, no any prodromal symptoms, no any addiction, no any past history. On examination, just icterus, rest of thing was normal. Lab value showing cholestatic pattern of jaundice, very high bilirubin, alkaline phosphatase, viral markers were negative. So at this point, we have to differentiate it between the whether it is intrahepatic cholestasis or extrahepatic. So first line investigation now it is ultrasound abdomen to look for any biliary tract dilatation, which was showing a dilated CBD and intrahepatic biliary radical. So MRCP was done, which showing very likely to be periampullary lesion. So I done the side viewing, which showing a very large ulcerated and proliferative lesion over periampulla. So with clinical examination, looks like it's malignant. I've taken the multiple biopsy, and due to his very high bilirubin and maybe requiring neoadjuvant chemotherapy and the surgery, patient will require ERCP and CBD stenting. With difficulty, I done the stenting and subsequently his bilirubin came normal. Now, patient is undergoing chemotherapy. But the biopsy suggestive of very poorly differentiated adenosine. So, the take-home message that every single symptom and the sign in the we must have to evaluate it. Even the neoplastic disease can present with only single symptom. Even the younger patient can have malignancy, and whenever it is indicated, we have to do the endoscopy, ERCP, or imaging evaluation. Thank you.